Incredible. Supplementation in patients with biphosphonates. Osteoporosis and people with osteoporosis have a lot of concerns. The disease itself is one of them. But the problem of loss of bone mass means that they also have loss of the mandibule, of the jaw, the bone itself. So if there is a need of a dental implant because there's an accident, they can be worried. And this will be one of the things that we will discuss with two renowned odontologists. Let's welcome Dr. Francisco Borrego Salgado from the Salgado Dental Institute. He's an odontologist, and he also holds a degree in nursing. Welcome, Francisco. Thank you. These are your mics, and you can start with your presentation. Thank you. Indeed, I'm a dentist and odontologist, but before that, I used to work for 16 years as a nurse in rheumatology, urgency, the ER, and others. Can't you hear me? Is that better? Yes. I said I am a dentist, and I specialize in oral surgery, or specialize in regenerative surgery. But my passion comes from my experience as a hospital nurse for 16 years in different units. In rheumatology, traumatology, in the OR. So I have different points of view. Those who are close to the patient, like the nurse, because sometimes the doctor is doing many different things, doing 200 or 300 different things at the same time, and they can't because the system is designed this way, but well, maybe they can't pay as much attention as they should to patient. But as a dentist and specialist on surgery, I would like to focus and debunk the myths that have been affecting many of patients with biphosphonates. Many. I would like to debunk this concept of I cannot afford this dental treatment, my quality of life cannot move on because I will have the famous necrosis, the painful ulcers, and I will having a hard time because I'll have an injection or treatment with biphosphonates. So I just wanted to share a message of optimism, and I would like to debunk this myth because nowadays we know that this is not the case anymore. I am very glad to have listened to Carmen and her colleague, because I fully agree with everything that has been said. Sometimes we are all put into the same box, and it's not true. Every situation and every clinical condition is different. We cannot globalize. Sometimes you hear a specialist like evangelizing, talking about topic, when in actual fact, what we want is for people to listen to the following, to foster the resources that we have, minimize the risks as much as possible to obtain the most successful result. So first of all, I would like to thank the foundation and the guys from Spain Lab for always paying attention to these things. They are researching on regenerative medicine and surgery, making contributions to both patients and professionals from a clinical point of view and from an educational and research point of view. I would also like to greet my friend Alberto Salgado, who is the person with whom we are trying to use biology so that it can express its entire potential. He wasn't able to come because he just became a father, and that's why he's not here with us. According to what I heard, you already have a lot of level. If I bore you, please let me know, because you may know as much as I do, if not more. Bisphosphonates, are drugs given by the rheumatologist or other specialists without giving explanations, maintaining vessels strong, reducing the risk of fractures and cell proliferation in some tumors. But these drugs are stigmatized. I discussed this with Dr. Baquero, to whom I would like to thank for his availability. But they are our allies. As Carmen said, there's an A side and a B side to everything. The B side, or the not so good side, should be minimized, and we should foster the first side. If I need to hurry up, just let me know. But these are diseases for which bisphosphonates are used. We cannot put everybody into the same box. It's not the same to treat osteoporosis or OP, where I can say that the possibilities of having a problem with the maxillary bones is minimum compared to a patient that has hypercalcemia or a treatment because of a tumor. We cannot put everybody into the same box. We need to analyze and minimize the risks. So why am I providing these names? Because everybody might know Fometa, Foxamat, and many other drugs. My mother is also taking these drugs, but not all drugs are the same. Some are 10,000 times more powerful than others. And as Carmen said, we cannot label everybody in the same group just because they take bisphosphonates. We do consider other aspects. Now, what do bisphosphonates do? As Pilar Saez said, she referred to the scale of bone regeneration, right? In order for the bone to generate, it needs to be activated. This requires a destructive process. Some cells, called osteoclasts, first destroy so that we can later generate. This scale in patients with OP is altered, and bisphosphonates make these cells destroy the muscles and unbalance the scale. In treatments in patients like these are maintained latently to ensure the bone is not destroyed, but they also prevent tumor cells from replicating. This process, why do we have this myth and this problem with our mandible, with the maxillary, or both the upper and the lower one? Because they are much more sensitive than the rest of the bones in the body. That's why it is said that patients following bisphosphonates treatments are condemned not to rehabilitate their mouth with an implant, or not to mention an implant. I'm talking about difficult extractions, curettage, and many other things. Since the exchange rate, which is this bone that activates and deactivates to regenerate, in the jaw is much greater than the maxillary, almost always we see the problems in the bottom side of the jaw. But the remodeling rate, which is what we talk about, is a heterogeneous concept, a weird one, is that bone that will rechange throughout the natural life of the jaw. In the jaw, it's 40%. So your jaw today will be 40% different next year. There's much more activity. And that's why bisphosphonates are much more sensitive to locations like these. And that is why, in some cases, we see osteonecrosis of the maxillary. These injuries, these lesions that many patients have said to me 30,000 times, I don't want to do anything because if I have a lesion, I will have necrosis of the bone. The doctor said this or that. But my answer is no, it depends. In some cases, it is true. But in most cases, it can be done. So what is the action mechanism produced? Well, if you are taking bisphosphonates and there is a reduction of this bone exchange to maintain it as it is, in parallel, the side B is a reduction of vascularization because the exchange itself means there is no longer that need. In the face of trauma or infection, a necrosis can occur. Now we are referring to infections, not in the face of an invasive surgical procedure, such an implant or some other surgeries. This will happen to anyone. So sometimes, even if we do not want it, it will be necessary. We won't leave an open infection just because we're taking bisphosphonates. What are the risk factors? It's not the same to consider a patient taking oral bisphosphonates or IV, or it's not the same with the type of bisphosphonates or the power. We've seen that there are drugs that are much powerful than others. The age is not the same. Every decade things get more complicated. The risk rate increases as we change decade. And there are concomitant diseases, use of anti-inflammatory drugs, powerful such as corticosteroids. This means that the inductive process to be carried out to discern between drawing all the balls out of a sack full of balls, what is important for us to be able to minimize the risks, depends on this and many other things. For instance, where we will provide the treatment. And we said that the rate is much more likely for exchange, much more intense in the jaw. And of course, if we do it on the top, on the upper part, there will be less risks than on the bottom. And it's not the same to do a tooth reconstruction than any other more complex procedures. And this is what I would like to insist on. This is as important as taking the drug. There are no excuses. The doctor, the professional, must do its bit. But if the patient does not, this will be impossible. We need to have better knowledge, be more up-to-date, have more time to treat, do a more exhaustive clinical record, and the patient should do its bit as well. This is up to us. And this is where the guys from Spain Lab who are here, they're very affordable. You can talk to them. They are rethinking about this. How can we help the biology to express itself in its utmost potential? So what am I trying to say to you with this? Are we the patients taking bisphosphonates sentenced not to follow any dental treatment? The answer is no. We can do it. But we can only do it by doing it well, when the professional and the patient do it well. So what do we do? Remember these concepts. I don't want to bore you. I'm running very fast. I apologize for that. But our doctor needs to prepare an exhaustive clinical record of everything, of all the synergies and all the antagonisms that could be, determining this degree of risk and optimizing the resources that we have in order to have reliable results and stable results. So remember this, degree of risk and optimization of resources. This is a table that the Spanish Osteomatology Association published, distributing the rates of risks in different levels. There's low risk, moderate risk, high risk. So by doing all of these things, a patient can go from high to moderate risk to low risk. A low risk is a possibility among 10,000. So, if we start the game by losing 2-0, let's make sure we don't start by losing 5-0. Let's try and draw or win the game. So what do we do? And this is what I would like to mention. Our doctor has its part of responsibility. As healthcare professional, I see this on the day-to-day. I'm not here to blame anyone. But if we don't do whatever is possible to minimize risks and express and maximize resources, we cannot achieve it. And we will have a higher risk and more possibilities of developing a problem. So I have patients to whom I've made bisphosphonate implants. I can't tell you the number. But we have a commitment, a tacit one. They won't blame me because I know I'm doing things well. So if I see tobacco stains, I can smell it. The man or the woman doesn't do any exercise. They don't follow a healthy diet. Then I won't be able to help them anymore. I try to operate everybody as if they were my mother. My mother has an implant. So the thing is, once again, let's minimize risk factors and let's optimize everything that depends on us. But all patients, my patients here, I also work in Salamanca, in Madrid. All patients leave it everything till the last minute, until there's pain, until there's a problem, until there's an active infection. Maybe it's too late. Remember, not everything is due to a problem in the mouth or an extraction of a tooth. These responses can also be triggered because of an infection, and caries is the most prevalent disease in human biology. All of us here likely have more than 1, 2, or 3 caries. We are all infected. I cannot say so in this day and age, but I think you know what I mean. Prevention is key. I don't like to speak about my experience, but 60% of my patients only come when they have pain. So let's not wait to have a symptom to go to the dentist. You know, a necrosis doesn't hurt and is generating a cyst. When they come with a fistula or with a cyst, then we remember the dentist. We don't charge for the first visit or for cleaning. So let's go to the dentist regularly. Let's detect a problem before it happens. And the question is, what is most important to express biology in its utmost potential is to follow a healthy diet, a balanced one. And this is where the guys from Spain Lab have made a difference, and they've changed the way I apply dentistry and the way I operate. It has changed since I'm using these supplements. These are studies that have been published, several levels in the pyramid of evidence showing that in Spain, 80% of people do not follow a healthy diet or a suitable diet. It goes on to say that there are systematic reviews on the top of this pyramid, along with meta-analysis, that say that vitamin D is key for the exchange of bones, for the assimilation and integration of implants and other pathologies. But we're not only talking about implants here. Vitamin D is a regulator, along with other hormones and substances, of the proliferation and cell differentiation. So, when we put an implant, we need to make sure that all of these cells, proteins, thrombocytes, stem cells, monocytes, osteoblasts, they should all be activated, and they should have this gas, this potential to be able to express themselves to the maximum level. And this is regulated by and large by vitamin D. This is not what you assimilate from the sun. You need it for many other things. And 80% of the population have it low. Vitamin D, ferritin, and many other things. So, what do patients do to optimize these resources we have? Let us foster, let us promote, and let's obtain reliable results as long as we have good habits, good diets, and we visit our dentist to detect an altered need in time.
If you are able to have your perfect diet, and I go through several tests myself, but I test many more people, and if I spot great nutritional needs, no one's having a proper ferritin or oligoelements, so sometimes you need to give an extra punch to your body in order to facilitate and support our biology so that it makes us grow. I mean, it's not the same moving from Seville to Barcelona by the high-speed train than by bike. Yet, with these, we manage for this potential to be fully expressed. So, guys at Spain Lab have developed some products that I have inside my toolkit, as well as many other dentists, of course, so that it's not just helpful in the procedure, but also in prevention, which may make things go awry before we begin. So it's giving you the most of your nutritional needs, so that in the pre-surgery stage, but also in post-surgery, you're always covered. And it also has a protein, the Ovoset, and proprietary patent to bring the calcium to the bone. And this is a product that I would suggest you trying, because it has changed my life indeed. And even more, not just from an odontological or surgical viewpoint. I've had much good feedback from my patients when they come and tell me, well, since I've been taking this, my hair looks better. Like I've gone out for a walk, my knee hurts less. I have a clinical case, if we have time for that. I have a greater sexual vigor. So I couldn't tell you why, but it is, and it's happening. And so we can help biology express itself, because often we are lacking in some aspect or another. These food supplements have different protocols based on what you may be in need of. One may be pre, the other post surgery, and but they may balance your gut flora. They minimize the possibility for infections. They would favor vascularization, remove necrosis, decreasing inflammation. And if this is causing maxillary necrosis, let's try and help our body preventing that. And this is a product I love when it comes to prevention. And why am I telling you this? Well, this product has a series of components that help us preventing these pathologies, because it's not just what happens after you remove a tooth, but what happens in your flora, in your daily life. And what's its maintenance? I mean, I can do a culture for any one of you, and you would be frightened to see what's in your mouth. And knowing that in recent studies, the actinomyces, which is a bacterial gram-positive, may lead to a necrosis in the jawbone, let's try and keep it at bay, along with other effects. Let's try and not to provide it with a breathing ground so that we can have a better healthy condition. So let's help our dentist, let's have the proper diet, let's supplement it if necessary, and let's try and prevent these from happening. This is something that's clear in Spine Lab's minds, and they have this notion, this biological odontology. But it's true. Biology is really thankful. If we support biology, we will get these hack 3 times back. And I can attest to that. I've seen that myself. My protocols have changed since I've been using it. And let me conclude with this example. This is a patient with a necrosis in the upper jawbone, and he was having IV bisphosphonate. No, sorry, it was oral bisphosphonate. Anyway, there was discomfort, pain, he couldn't use the prosthesis, diabetes. Anyway, the thing is, I'm not here to show you any ugly pictures, but here you can see where the bone is exposed, where there is an inflammation. This is a necrosis area. And this closed bone, this closed bone is what's brought the problem to him. Other than the age, he was 90 odd, but he had poor hygiene. We tried and help him, and see what happened 40 days after. Same patient. I mean, I phoned Alberto and Antonio, and I said, well, how come we have moved from here to here? How's that even possible? How come we have seen this bone regeneration? I mean, it's like magic. I mean, if this is so, it's like we found black powder. And excuse me if you are sensitive to these kind of pictures. I mean, I do not know much about cars, but I can tell a Ferrari from a Chevrolet. And this necrosis area, well, you can see what's the status of the mucus here. You can see how it changes in here. And so, to me, this has been quite a breakout. And I want you to keep that in mind. So it helps minimizing the risks and promoting its virtues, both on the clinical side and on the patient's side. Thank you very much. It's been a pleasure, and this is precisely a sentence that came out yesterday by Dr. Burgess. And he would also say that I operate much like I would with my mother. Thank you. Please stay with us, because we will keep on talking about this topic. And now we will have Dr. Pablo Baltar, and he's online with us. Dr. Baltar, with doctor in Santiago de Compostela University, with he's the director manager at the Clínica Baltar, and with several postgraduate degrees and over 15 scientific publications and papers in both national and international congress. Welcome and good afternoon, Dr. Baltar. You're in Santiago de Compostela? Yes. It's a pity I cannot be here with you, but again, I have a tight agenda, but hopefully I'll be here online. Well, it's great to see you nevertheless, and again, feel free to share your presentation. Yes, I will.
Vale, perfecto.
Thank you very much to OAFI for their invitation and for this splendid organization, to Dr. Borrego for their presentation, and to Spain Lab for inviting me. Well, my presentation will be focused on what Dr. Borrego was telling us about, on this required balance, specifically on diet. We have seen throughout this Congress what osteoporosis, OP, is this balance between the loss and the reconstruction of the bone mass, and this imbalance leads to a significant loss in the scaffolding, so that we have a proper anchoring in our teeth and therefore in our implants, and therefore there are many instances where we find patients with bone conditions and along with some other conditions. And it's not like it was some years ago where you could have a hard time treating this. And let me tell you that here at Santiago de Compostela, that's a call for hope for our patients, because indeed this can be approached with several guarantees. Not all instances, but a significant percentage of cases can be rehabilitated. So clear yes here in that patients with OP can be treated with implants. They can be recovered by resorting to implantology. I will go through a series of clinical cases so that you can see what's our day-to-day. This is a patient with osteoporosis that was treated with some vitamin D and calcium supplements from Osteoplan provided by Spain Lab. This is a patient, and she has consented to show these pictures of her. This was a patient that had attended several hospitals and had not been given a proper solution because of her bone condition, and we saw that we could approach it without an issue. We took away the bridge in the right hand side that had failed, could not be rehabilitated, and we put the implants, and some 3-4 months later we put the end crowns, and with a good deal of satisfaction on her side and no problem in chewing whatsoever. Then, a more complex case. This patient had been treated with bisphosphonates, as Dr. Borrego was telling, with a failed bridge in the lower left part of the jawbone. We consulted this with a rheumatologist on the removal of bisphosphonates before the surgery. Here you can see failed bridge with some terminal injuries that led to the removal of the bridge, and after removal some bone regeneration because the implants could not be put at the time of the extraction. So this is 7 days after, and of course these vitamin supplements were helpful. Then 15 days after, and then a month after, the post-surgery and the placement of successful implants. And as an individual with bisphosphonates, and some years ago people would say that you couldn't treat that person and it would lead some sort of a prosthesis. Well, with these final crowns and no issue whatsoever, neither in surgery nor in the post placement of the implants nor the crowns. Now let's take a look at some funny examples. And probably these are the ones that surprised me the most. These are young patients with no pathologies, with a good bone pool, with a good bone reserve. And let's take a look at an odd case. This is a patient, female, 35, 36 years old, non-smoker, non-diabetic, no apparent issues in her clinical record. And then we put the implants on this patient. Apparently there should be no complications whatsoever, but yet we found a couple of issues. First, on the right hand side of her jawbone, in this area, we found an extremely soft bone where we could almost put no implant, and same for the other side. Indeed, they were somehow left over the bone crest. And how come it happened for this patient, which apparently was to be an easy case? Well, because she was having no milk, no balanced diet, despite the supplements in vitamin for her patient that would lead this to success story afterward. We found that at the time of placement we were almost unable to put these implants, unlike in the previous cases, in the case of an OP patient with bisphosphonates. Now another example, similar one, no condition, with a healthy normal bone where we find a nutritional deficit. According to the x-rays, we can see these implants here on the higher right side of their jawbone. Apparently no issues for this patient. Everything was to be normal, it was all promising, and yet we found that in the left upper part we couldn't place it because of a poor condition of the bone. And after discussing this with her, we found out that there was a nutritional deficit, poor diet. She wasn't taking enough calcium and vitamin D, as Dr. Borrego was saying, and therefore we were unable to place the implants. So you can check on patients with known bone conditions and with bisphosphonates, and we've been able to place the implants without any issues, but of course with some pre and post care. But then for patients where apparently they should have no issues on any sort of surgery, we were unable to because of their very low quality of their bones. Why so? Because they were having an improper diet, mostly deficient in calcium and vitamin D. Same case for this apparently healthy non-smoker, non-diabetic patient, 33, and same thing here. As you can see that this is installed, and this was done through a bicortical anchoring, where we put this wide implant, but this was a bone with very poor quality because of the same thing. Because later she confessed, as is often the case during the surgery when they tell us the truth and nothing but the truth, and they tell us about the impact that some foot disorders has had on him, and so that bone was not in the best condition for an implant. As Dr. Borrego was pointing out, there is a significant nutritional deficit in the Spanish diet, but also globally. Why so? Because we are no longer having milk, no longer having dairies. Apparently there is a growing trend in decreasing the use of milk and dairies, and we are facing many issues, as we are seeing in our offices, on patients that we cannot place any implants because of nutritional deficit with no underlying condition. Even more so in the case of vitamin D. Why is that happening? Because there is a growing trend on being less exposed to sun, and this is leading to several issues on the bone biology, even more so than in the case of conditions where like patients were being stigmatized, where apparently dentists could not come close to them because of their OP, or like it was like there was no way that a dentist could touch them. But now we have found that this is no longer true. The science is developing at such a pace that we are shifting rather on the burden on the nutritional part than on the underlying conditions. So again, as I was telling you, I would encourage you, as I do with my patients, to increase their milk consumption, and of course the specific vitamin supplements, because it will support them into having a proper bone biology. Much more if you would have an underlying bone condition. It's very important, the diet, of course, because the food, even the ones that we might consider to be healthy, are not so much, because the way we handle them both in our house kitchens but also during manufacturing are removing much nutrients from this food, and it's important to have what we can have elsewhere through supplements. Our clinic for some years has started doing an anamnesia, so that for all patients that will go through some surgery or an invasive treatment, we ask them about their dietary habits. We ask them, of course, about underlying conditions, previous operations, and so on, but we ask them how they feed themselves, whether they are on dairies or not, milk, yogurts, because in our daily practice, in our evidence, we have seen that this is a crucial factor. And even if they have a proper diet, I've seen that I often need to add some extra supplements and vitamins in order to help the body regenerating, so adding fuel to the regeneration, because often this surgery is invasive and harsh, and I need for these patients to have this extra punch, as Dr. Borrego was saying, by using these vitamin supplements that are specifically designed for odontology. We have found many good surprises. I'm much of a proponent on bioactive compounds, for instance, hyaluronic acid and so on, but I think that we need to support the body, because the regeneration is not enough. We need to add it a bit more, and we have now that possibility. To all patients coming to our office, we apply the Spain protocol with very good post-op results, and I need my patients to have that extra fuel that would allow them to correctly regenerate, and so that there is an implant that's incorporated into the bone, and we have some specifics that are really helpful on that. And basically through these type of compounds and through other protocols that we implement. In the case of osteoporosis, we start like a couple of months before, adding this extra fuel so that the calcium and vitamin D would help the bone being in a better condition. And then with bisphosphonates and consulting their rheumatologists or traumatologists for the removal, for the withdrawal of these products. And about to conclude, we need to find a balance between the underlying bone pathology and the diet. We believe that diet is very important, and this is how we also approach it with our patients. And thank you very much. I'll be attentive to any questions you may have. Thank you very much. Thanks to you, Dr. Baltar. I think that Dr. Baquero wanted to add something. Dr. Baquero, coordinator at CSR at the OAFI Foundation. Thank you very much, Doctor, and thank you very much to Dr. Borrego in the previous presentation. The truth is that you've shown us a solution for a true problem in OP patients. You indeed look at implants quite fearful because of the lack of a bone bed. But this is a solution, a bioactive solution, and let me stress this. You have probably seen in your folders, in the proposal by Spain Lab for a free treatment for all the attendees. So make good use of this. You need to get in touch with your expert, be it the traumatologist, rheumatologist, or dentist, so that they get in touch with the Spain Lab and they will provide them with this free treatment. Thank you very much. I would only like to thank you, the speakers, and also like to thank Spain Lab for their gratitude. Thank you.
Gracias, doctor Baltar. Gracias al doctor Borrego nuevamente. Gracias a Spain Lab.